My name is Chloe, and today I will be talking to you about keratoconus, which is a disease that affects the cornea of the eye. As a small introduction on what exactly keratoconus is, it occurs when your cornea, the clear, dome-shaped front surface of your eye, thins and gradually bulges outward into a cone shape. A direct quote from the Mayo Clinic. You can see a simplistic diagram here that compares the normal shape of a cornea to one that has been deformed from keratoconus and is protruding outward. Keratoconus causes significant morphological changes to occur at every layer of the cornea, imaged to the right. The corneal epithelium becomes thinned and experiences a loss of basal cells, which are cells that can regenerate and play a role in repairing damaged tissues. Therefore, this is an extremely damaging effect. The anterior limiting lamina or Bowman's layer, which helps to strengthen the cornea, experiences breaking due to weak collagen fibers, or in severe cases, a complete loss of this layer can also occur. The stroma, which is the thickest layer, is thinned and experiences a reduction in the number of collagen lamellae. Lamellae, which make up the stroma, are composed of bundles of collagen fibers and are responsible for providing the stroma its strength. Therefore, this is another extremely damaging effect. The posterior limiting lamina or Descemet's membrane experiences folds or breaks due to corneal thinning and stretching. These often start out as stress lines, but breaking occurs with disease progression. Finally, the corneal endothelium experiences endothelium cell loss. This reduces corneal transparency and leads to further blurring of vision. The exact effects that keratoconus has on the corneal endothelium are less understood. However, research suggests that ruptures in the Descemet's membrane are responsible for this cell loss. We will now discuss physiological changes. Starting with corneal protrusion, which is the outward cone-like bulging effect, this occurs due to the overall thinning and weakening of the cornea as a result of the factors on the previous slide. This corneal protrusion causes irregular astigmatism, which is the loss of the cornea's normal dome shape resulting in abnormal curvature. We can see this displayed in the photo here, where this cornea has reached a significant stage of disease progression. We can see the irregular astigmatism with this asymmetrical cone-like curvature. The astigmatism causes a reduction in visual acuity, which means vision sharpness and clarity decreases. A significant metabolic change is the formation of a Fleischer ring, which manifests as a yellowy-brown ring around the cone. It is commonly believed that they form from the deposition of iron in the posterior limiting lamina. However, the exact reason for their occurrence is still being studied. The photo in the bottom right corner was taken using a slit lamp and shows the iron deposits that have formed a Fleischer ring. Researchers suggest there may be a link to mineral or nutritional deficiency caused by the disease, but hopefully this is something we will have a better understanding of in the future as researchers continue to learn more about metabolic changes related to keratoconus. Keratoconus leads to a number of impairments after severe progression. Blurred and clouding vision is a side effect that can lead to difficulties with both near and far-sighted vision. Sensitivity to bright lights is very common, and glares or halos can form around lights. There can also be difficulties seeing at night and eye pain that can reach such severity that can cause headaches. Diagnosis rates are less reported since the disease can often go undiagnosed. Approximately 1 in 1,000 Canadians have keratoconus, and worldwide there are approximately 25 cases per 100,000 persons per year. Researchers are finding that the highest rates occur among those 20 to 30 years old and in those who are of Middle Eastern or Asian ethnicities. Causes for the prevalence among these age and ethnic groups is still trying to be understood. The cost of managing the disease can become quite difficult due to its rarity in our healthcare system. The Ontario provincial government is reviewing the results of studies to determine whether funding for treatments and surgery is an option. Some private insurers may also offer funding, however, this is assessed on a case-by-case basis. Essentially, the cost of treating keratoconus often falls largely with the patient once they are past simpler solutions such as glasses or contacts. There are many different diagnostic methods available for use. Ultrasound biomicroscopy and ultrasound pachymetry are two different ultrasound methods available. There is also a slit lamp examination, which you may have seen during common eye exams, and finally a corneal topography exam. Treatment methods are based on which stage of the disease a patient is in. In the early stages, glasses and contact lenses are suitable and a much more accessible form of treatment as opposed to surgery. However, with disease progression, glasses won't be able to provide enough vision correction and contact lenses will not fit properly on the eye. In the intermediate stage, corneal cross-linking is a surgical procedure used to add bonds between collagen fibers in the eye. It is a one-time procedure that is very successful in preserving corneal strength and slowing progression. However, it cannot return the cornea to its original state and often requires the top layer of the cornea, the epithelium, to be removed in order for the eye drop medication that is applied before the procedure to work as intended. In the advanced stage, corneal transplants are performed. It is a fast outpatient procedure typically lasting only an hour. However, the patient's vision can remain blurry for a period of 3 to 6 months following the procedure. A second limitation is that glasses or contacts are still usually required following the transplant in order to provide clear vision. My proposition for a change to the diagnostic procedures of ultrasound biomicroscopy and pachymetry is for the implementation of non-contact UBM and UP machines. These diagnostic methods require a fluid to be applied to the patient's eye and for the probe to make direct contact. This can be very uncomfortable for the patient and lead to a very time-consuming procedure. A non-contact machine would improve patient comfort, making it easier to get a clearer scan and therefore reducing procedure times. This could allow for more patients to be imaged in a single day, which ultimately lowers procedure costs. A non-contact machine would also eliminate the need for purchasing the eye fluid solution, which also lowers costs. We will now be focusing on UBM machines, which is shown in the image here, and their general technical specifications. Its main components are the arm labeled B, the probe labeled A, and the screen that displays the final image. The transducer, which is inside the probe, is responsible for emitting ultrasound waves that propagate off the tissue and are emitted back to the transducer. These echoes are sent to the computer to produce an image, and its operating frequency is 35 to 100 MHz. Spatial resolution in UBM is quite high compared to other forms of ultrasound imaging in order to be able to produce such high-quality images of segments of the eye. Axial resolution is between 25 to 35 microns, and lateral resolution 50 to 60 microns. The imaging procedure is two-dimensional, which is produced onto the screen labeled C. The depth at which transducer ultrasound waves penetrate tissue at is 5 to 7 millimeters. This is sufficient for imaging necessary segments of the eye. The field of view that can be imaged by the transducer is 5 mm by 5 mm, and the standard speed that ultrasound waves penetrate tissue is between 1,530 to 1,540 meters per second. Finally, the standard focal length is 12 mm. There are a couple of specific settings used for imaging keratoconus with a UBM machine. Transducer frequency is set to 50 MHz and resolution 50 microns. Tissue penetration is only 4 mm, as an image is only needed of the top layer or interior segment of the eye. The field of view still gives 5 mm by 5 mm, and the ultrasound wave penetrates the tissue at 1,540 meters per second. These specifications are as such in order to give a clear image of the anterior segment of the eye and allow for proper diagnosing. Quantel Medical's Absolute UBM ultrasound platform is a modernized UBM machine currently available on the market. Similar to the UBM machines in the previous slides, this machine has a handheld UBM probe and screen that displays the image. Some features include a position sensor within the probe that allows for advanced real-time positioning data during the scan. The greater linear transducer movement also allows for optimized image quality. The technical specifications are similar to what we have seen and discussed in the previous slides. Transducer frequency operates at 50 MHz and provides both axial and lateral spatial resolution at 35 and 60 microns. The ultrasound wave is focused 10 mm from the transducer for sharpness and image quality. The linear transducer movement is 16 mm, and the machine provides a 2D scan. In terms of system cost, there is a range between $16,800 to $19,650 US. Associated costs for this machine largely include education. The operator of a UBM machine needs to be very skilled, and therefore large sums of time and training are needed. Maintenance and repair costs should also be considered as associated costs to owning this machine. Here are two typical clinical images of keratoconus taken from UBM machines. We can see that there is a uniform pattern across all these images, as there is advanced anterior bulging of the cornea. In other words, it is clear in each of these images that the patients are in an advanced stage of keratoconus disease progression. Many of the characteristic features of UBM that we have discussed in the last couple of slides are present within these images, specifically image resolution, penetration, and field of view. So here we are looking at two different 2D clinical images of the anterior corneal segment. We are provided with this clear overall view from the high image resolution setting. We are able to see various corneal layers, as well as the defined protrusions. The shorter tissue penetration depth from the ultrasound waves in the UBM probe gives us the capability to see the anterior layer perfectly, which in this case is the layer we would be most concerned with when making a keratoconus diagnosis. Finally, the 5mm by 5mm field of view gives us a large, full view of the area, and we are able to examine the full protrusion without any areas of interest being left from the image. Earlier in this presentation, it was discussed that there are multiple diagnostic imaging methods available for diagnosing keratoconus. We will now examine these alternative methods a bit further and compare them to UBM imaging. Ultrasound pachymetry is another form of ultrasound imaging that can be used. The main difference in this machine is that instead of providing an image like UBM, it measures corneal thickness. Therefore, frequency and resolution are relatively lower at 20 MHz and 1 micron. The number of measurements taken, or sampling rate, is 400 MHz, and it has a large range for the distance of transducer ultrasound waves to the tissue at 220 to 1,100 microns. The speed that the waves penetrate tissue is higher than UBM at 1,640 meters per second. The slit lamp examination and corneal topography exam differ greatly from UBM and ultrasound pachymetry, as these are alternative forms of imaging that are not ultrasound-based. Therefore, the technical specifications listed differ greatly from the ultrasound specs we have covered. The slit lamp examination uses high-intensity light beams to illuminate the eye, and a combination of lenses allow for magnification to be adjusted, allowing for a clear image of the area being examined. The means of illumination is an LED light source with slit width and length between 0 to 8 mm and 1 to 8 mm. The microscope can provide magnifications of 6.3 to 40 times larger. Imaging is done with an SLR camera, and there are 5 mechanical apertures. A corneal topography exam captures multiple images of the cornea, which allows for analyzing and detecting irregularities in corneal shape. Corneal coverage is very large at 9.8 mm and resolution at 1 micron. The axial radius is 2 microns at 4 mm, and the final image output is a corneal map. You can see a small image of a corneal map on this corneal topography machine photo at the bottom right of the screen, noticing it looks quite similar to a heat map. This machine uses colors to represent corneal depth, curves, and thickness. In this presentation, we covered keratoconus in relation to the changes and complications the disease causes, the use of UBM for diagnostic imaging and diagnosing, and further alternative diagnostic methods. Recommendations for future improvements to UBM include the use of a non-contact machine, which was discussed earlier in the presentation. Further recommendations include integrating the use of a 3D ultrasound imaging procedure to allow for a more thorough view of corneal curvature. A final recommendation is to agree upon and set uniform measuring procedures for standardized imaging analysis. This would require further research in the area of determining diagnosis requirements. However, it could dramatically lower the number of cases that go undiagnosed. If you would like to go back and review anything that has been covered in this presentation, the topics and associated slides are listed below. Thank you very much for watching, and I hope you enjoyed. References will be listed on the next set of slides.